The best money you're ever going to make is if you're willing to go do shifts somewhere you don't necessarily want to live. And nothing against the rural Mississippi area, but I can make a great hourly rate there and I can be a locums doctor there, but I'm never going to move there. And so those places are forever having to offer pretty high hourly rates to get emergency care out in their facilities.
That's probably true in almost the rural communities are resource constrained.
Right. It was easy to get people into the academics. The hospital, a lot harder to get providers out into the satellite clinics. And I think the same would be true as John said, in the rural situations.
Years past, you go back 30 years ago, these rural areas and to some degree the urban areas were willing to fund the relocation and also to pay a premium for providers and nurses. But what I see now is with the cannibalization of all these entities, the hospitals, et cetera, by the big integrated delivery networks, what I've personally seen is they don't care. If there's no GI service in this area and they own the entire market plus a big urban market too, they say, just drive 2 hours to the big city. We don't care.
And so not every community can afford, or is it even viable to have, a plastic surgeon, a neurosurgeon, and a cardiologist. So a lot of these rural resources are imperative for these companies. If they can go to an ER, you can tell a link to a telestroke or be able to talk to a cardiologist at a cath lab. That makes a big difference.
With the advent, certainly increased use of telehealth, I think that has been helpful. And at least in Colorado, we have several areas that have no broadband access. And so one of the big pushes has really been, how do we even get them the internet capabilities so they are able to essentially take advantage of more of these, whether it's telehealth or other digital health tools that they might that might help, again, provide them the care that they need in different ways.
Interesting that you mentioned with the broadband. AMA recently has very into talking about health equity, and they're recognizing a fast internet connection as a social determinant of health.
Yeah, invited to a speakers board some time back, and how to improve healthcare, access to healthcare, and we actually were focusing on Baltimore. I did my fellowship in Baltimore, and we were looking at how to do that and access to broadband. Ironically, in a major city, is still an issue, especially when you look at the low socioeconomic neighborhoods. Sure. And we talked about incentives. We talked about incentives for getting broadband in, incentives for companies to come in to areas that were very run down, tax breaks and so forth for companies to come in, build that infrastructure around it. I think you almost need to look at it as a business case as to how to go into these areas. And that's got to be part of an innovation. You have to consider that as part of the innovation space.
So you mentioned critical access hospitals, and we could say federally qualified health centers in a variety of different areas. Like most of those places are just trying to keep their doors open and take care of the amount of patients that they're there to serve. And so this idea then, and I'm not saying that they're not innovative, but then the idea of how do they, again, generate innovation within healthcare, in some of those types of entities, I think is even more difficult. And who are the people outside of that to help support it?
Hospital groups allow entrepreneurs to make changes within the system. And if that doesn't exist, what's the process involved for entrepreneurs coming in and working with the system?
Innovation means different things to different organizations. That if you're in an organization that's barely getting by, you're looking to innovate to survive. If you're at a municipal or government level, and you're looking to innovate, you're probably looking to bring in work and bringing businesses into the area.
There are so many, I would say, healthcare providers that fly under the radar with whatever they are doing, because if they, come up with some great idea, whatever portion of that, I mean, within my previous organization, it was pretty much 100% of that belonged to my employer because I was an employed physician and the entities. How does that incentivize any healthcare provider within this organization to try and innovate when all you're going to do is take whatever that is? Like, to me, it was senseless. And I had one, I have one attorney who is one of my friends, and she was like, I looked into a few things, but it is that way across the entire organization. So yes, they bring in entrepreneurs, but this idea that they're going to grow ideas from within, well, why would any physician or other healthcare provider want to do that? And that's not true everywhere, but certainly in the system that I was in, that's the way it was.
No, I completely agree with you. Why would anyone do that? Right?
Yeah.
Why would an entrepreneur do that?
Where I am right now, they have a totally opposite culture. Their whole thing is, this person does really good in business and really good as a physician, and that's why we want them on our staff. And so you have a little bit more latitude. So we're actually building an innovation funnel where we are focused on publication, keeping a competitive edge, and serving patients better. So we have a way that we evaluate a particular need. Like right now in the emergency department, we're looking at artificial intelligence to speed along just patient flow, making sure we don't misidentify septic patients because, one of the vital signs slips through, things along those lines. And so we're actually in the process of interviewing multiple AI companies. We're going to look at getting publications out of it. And this is very encouraged. And I think that's a major difference from other locations where I've worked.
You talk about that negative feedback loop, and how do you break that? And I don't know if you can. The question maybe not how you change it, how do you ride it? How do you manage that better? In terms of the socioeconomic space, I like what John said. There are economic opportunity zones. This is one of the things we looked at with Baltimore was, bring the major players in the internet infrastructure in. Healthcare, you've got the big players there already, but you have to incentivize them to get out to satellite locations, figure out how to get those interactions with patients, whether you bring them into the hospital or you touch them at a distance. The telemedicine piece is something that's very big because at some point you're going to outrun the number of specialists that you have. And I'll tell you from my experience with teleradiology, you could do that anywhere in the globe. And provide specialty care that way. But I think the first piece has got to be the more people you bring in, the more demand you're going to generate. It's going to be exponential. So how do you manage that feedback loop, right? And ultimately, the flip side of that is don't bring anyone in, right? And you have less demand. That's how you limit demand, but that's not what I think we're here for. Right?
There's another big group called the Purpose Investment Network. And this is like basically a group of very well-heeled individuals making investments that are basically tax write-offs for themselves because they don't even know if they're going to work, but they're focusing on healthcare as one of like three main items. But they're giving a lot of money towards innovation in low resource healthcare areas. So those are like focus on the opportunity zone and the type of investment dollars, maybe options.
What typically happens in my experience is once something starts to go downhill, whether it's a hospital or an institution, is it just, like I said, the positive feedback or negative feedback loop, it gets worse and worse. And finally, some entity goes out here and builds or starts a new system. And the old building is abandoned, the old system is abandoned, and a brand new system comes in. And it seems like maybe it's the bureaucracy that gets in the way because bureaucracies have a lot of inertia. It takes a lot of effort to change anything in a bureaucracy, and it gets to be almost to where administration just wants to kick the can down the road a little bit. I'll get another 4 or 5 years. I'll get my retirement, and I'm out of here. That's my impression that happens. I've rarely seen a successful, pull yourself out of the dive. A partner and I founded a rural health clinic we went and created the HIPSA, founded the clinic, and we had a little bit less enthusiasm within the community than we thought. It was motivational issues, and it was basically transportation. So we went out and bought a van and hired a driver to go pick these people up and bring them into the clinic, because it was always, well, I don't have a ride, this sort of thing. Well, HHS informed us they viewed that as a violation of the anti-kickback rule, and that we were providing something of value to these patients to entice them to come in to get care, and that cost the government more money, and it was considered a kickback, and we had to stop it immediately. You know, sometimes the government gets involved in, you know, with good intentions, and things go sideways.
I had the same thing. I owned a center, an imaging center, and we were saying, hey, you know, there are people who literally have problems coming in. They don't have a ride, they're elderly. You know, can we do this? And the same issue popped up. Nope, that's an enticement. It's something that's, you know, it's kickback. And we're like, whoa.
A Blue Cross insurance executive approached me, and I did some consulting for them a few years ago. And he told me that he and his company would, if they had their way, they would pay every orthopedic surgeon $1 million a year to stay at home, because orthopedic surgery and a lot of other healthcare was what they considered elective, and patients could survive without it. It wasn't anything that was life-threatening, whether they had a knee replacement or hip or whatever. And the cost involved with providing that care was astronomical. And if they had their way, they just pay everyone to stay at home. And that was really insightful, I think, to how they think about things.
That's it, right? That he hit it right on the head. The incentive system is all messed up in healthcare, right? I mean, we're physicians go into this because we want to help people, we want to treat people, right? But he's got that right. There's an incentive there. So health plans have to control costs. That's a different incentive scheme. And you know, we touched on this in the speakers bureau that I was in. And how do you, I think one of the important questions is, how do you change that incentive system? And how do you do it legally, obviously, right? And within the framework of the laws and so forth. That's, I think, you know, where we need to address it. Knowing full well that the more you want to get people more access, and the more you want to give them access to specialty care, it's going to cost them more. Someone's got to pay for it. How is that done?
And I don't have the answers, but I see zero motivation by institutions and bureaucracies to address it. At one point, we've all pointed out, except for John, I think he's in a very enviable institution there, where they actually, you know, they reward you for innovation. Every institution, IDN I've been in, has penalized innovation. Not only do we get the patents for it, but you've been wasting time on this when you should have been checking boxes on that computer. And you need to pay attention and do what you're hired to do, not frittering around doing that. Well, I see the same number of patients. I don't care. You know, you need to put in your time like everyone else. So I've not seen an institution reward innovation at all. It's like you need to go check your boxes and be quiet.
Well, have we bummed you out completely now, Michael and Katie?
There are some things that could maybe help us change the corner, or turn the corner. There's a lot of new billing codes for patients using wearables, talking to their physician via telehealth, and being able to bill for that. And a lot of times, you know, we have all these preventive discussions with our patients anyways, but it's actually something we'll be able to bill for and be able to monitor their progress from you know, rather than just having one blood pressure during a meeting, which is probably elevated because they're nervous. We'll actually be able to see trends. We'll actually be able to find things early. And, you know, hopefully some of these things can be, as you mentioned, based around weight maintenance, particularly for like the CHF and the cardiology patients.
This idea that you can get paid for remote patient monitoring, I think, is awesome, but I still have not seen a ton of uptake across the healthcare system. So what is it going to take for even those types of things? So sure, we're paying providers to do it now, leveraging technology, which is awesome. What do you think the other barriers are to uptake to help kind of move that into more what I would call mainstream? Because to your point, it makes it easy. It helps us be there, I think, for every step of the journey when, I always say I see a lot of kids 20 minutes once a year. So what happens the other 364 days?
I think the major thing that has to happen is increased awareness among physicians. AMA has their digital health and their telehealth playbooks that describe how to bill for them, what you can bill for. But I don't find that this is common knowledge among our peers. And so, and a lot of places, practice to the local standard, right? We're a little bit nervous to be the first one that prescribes the new medicine, but we're totally comfortable doing it once it's, standard for the area. And I think that's kind of a protocol. I think this is similar, but it's a protocol shift that has to happen within our communities, and it has to become the standard of care, whether that's a push from CMS or, AMA's, members or other specialty societies. I'm not sure, but I think that's something that would be a lot better than having a pandemic or a crisis to get us to use it.
Don't you think also, though, it has to be, and I don't know what the differences in reimbursement between remote patient monitoring and seeing a patient in the clinic. But again, reimbursement for services needs to be, skewed to the side where patients don't need to come in to be seen, because the reality is there's a lot of them that don't need to come in to be seen. But if I'm a provider in private practice or whatever, like what's important? Bring the patient in, bring the patient in, bring the patient in, because I get paid if the patient comes in. So now I'm getting paid to do a little remote patient monitoring, but I don't know how do we skew it more to not to not treat patients when they need to be treated, but again, to do what's right, have them come in when they need to come in, have them be able to monitor them at home when that's the right thing to do as well.
This kind of goes along, the new value-based metrics, right? You have this many souls, how many of them are meeting these milestones? How many are, if that's something like that's tied in, I think it forces us to get creative and start using the solutions that are available.
John, I think you're right. You change the incentives. Right. But in order to do that, you need to show them the outcomes, right? You need to show them why to change those incentives and why it makes financial sense for them to do so.
This will start in capitated systems where you get paid X number of dollars for a patient, and then you decide how to handle it. Then the telemedicine and the wearables and things like that, I think, will be integrated, sort of like a Kaiser type of situation has a potential first. All these preventative codes out here really don't reimburse you what they should. And that was part of what Katie was pointing out there, but you can't get it through these payers' heads. And their opinion is if you start getting paid more for virtual care, then you're going to switch to virtual care. It's going to cost the insurance company more money, and you will be taking advantage of the system and under fraud, waste, and abuse, and they see that as abuse. I think we need to come up with a TikTok of healthcare. People get so into TikTok. If you can engage them with their health like that, somehow that they would pay attention to it, I think that would be a wonderful thing. I don't have the answer, but I just see people sit down their phone with TikTok all the time, wasting time, and they're so enthralled in it. If we could do something like that in medicine, it might be helpful. It's
not just the billers, right? It's the payers. If you could show the payers a business plan that's profitable to them, that provides better care, quote unquote, right, with a significant component of telemedicine or non-office visit interactions, they have a reason to move there. But they're businesses. I don't think we'd be having this conversation with the single payer system, right? Because then there's no need for competition. With a single provider, single payer, where's the incentive for competition? How do you make change in that environment? My gut tells me it would be bad, and the example I use is the VA system, which probably has made some changes over the last few years. I'm not involved with that system, but there's that's the example. That's the de facto example. So how do you make with a single player on the block? How do you compete for a change?
Well, I think you'd have a two-tier system. You'd have the public system. Then you'd have the private system, which would be funded by cash pay, concierge, or even secondary insurers funding that. And, you'd have VA medicine on one end, and on the other end, you would have access to private care with that. And, the public option ends up being very expensive from the bureaucratic end of things. But, as long as you didn't outlaw private medicine to some degree, there'd be a lot of opportunity for people to innovate within that space. I don't like the idea of single payer. I think there's been, examples of that tried with good intentions. But if it came about, you have to look, how can we make lemonade out of lemons? And that's where I would look is on the cash-based end, whether it's providing care here in the U.S. or medical tourism abroad and taking people over. And I'm working with a couple entities now in that process in Mexico and the Caribbean with the current system.
I'm in agreement with Saul and Dr. J on this one. Particularly like when you talk about that you couldn't outlaw an alternative. I think that's been the big problem in other countries that did it. But, you hear about all the time, oh, Canada's system's so great. And while I think there's positive things to it, I trained in Buffalo and we took care of patients all the time because there wasn't an orthopedic bed in Ontario or there wasn't a neurosurgical bed in Ontario. And I thought, that's ridiculous. I mean, they couldn't exist on a health, as their health system couldn't exist if they were an island. They're able to do what they do because, what is something like 80% of their population lives within 100 miles of the border. And so people come across to Montana and Chicago and Buffalo because they don't want to wait 6 months for their orthopedic procedure or even like obscene amount of times for just like an EKG. I don't think those are as sustainable as people like to talk. But there's major value from having competition. When a patient can choose, do I go see this doctor or this other doctor? Suddenly both of them have to up their game to attract that patient.